Hello everyone. This presentation is to provide you with a brief overview and commentary on my case report following the rehab process of a patient who underwent a cryoneurolysis procedure prior to total knee arthroplasty. Additional details, as well as all references, can be explored through my accompanying scientific research poster. Following TKA surgery, postoperative pain can be a significant factor limiting rehab in any setting along the continuum of care, particularly when looking at a patient population that has dealt with long-term chronic knee pain. Effective pain control throughout the course of care is an important part of promoting patient recovery. There is currently no defined best practice for a precise pain control regimen following TKA, although multiple research studies have shown that preemptive analgesia, where a patient's knee pain is effectively reduced prior to the surgery, is the most effective for controlling postoperative pain levels. This retrospective case report focuses on a TKA patient who underwent a relatively new procedure preoperatively known as cryoneurolysis. This procedure is facilitated by a handheld device called the iovera that delivers compressed liquid gas, usually nitrous oxide or CO2, directly to the infrapatellar branch of the saphenous nerve and the anterior femoral cutaneous nerve. The very low temperatures of the gas cause temporary secondary nerve damage to the axons. It takes about 10 to 12 weeks for the axons and associated structures to fully regenerate, and during that period, pain signals that would normally be transmitted via these nerves are blocked. The ability to perform the procedure preoperatively allows for the preemptive pain reduction that is most desirable without oral opioid use. Preliminary research was able to demonstrate multiple benefits for patients who received the treatment when compared to a control group. These included decreased length of hospital stays, decreased pain in acute and subacute phases, decreased postoperative opioid use, earlier patient ambulation, fewer pain medication-related adverse effects, and higher patient satisfaction rates. However, I was unable to find any studies examining the effect of the treatment from a PT standpoint and if this pain control procedure has an effect on promoting early range of motion gains or tolerance to physical therapy interventions. The patient discussed in my case is a 73-year-old female with a history of chronic knee pain and end-stage osteoarthritis who underwent this procedure 1 month prior to her left TKA surgery. Additional measures during her care did include intraoperative femoral nerve blockade and oral pain medication following discharge from the hospital. The patient experienced excellent pain control during her hospital stay and was able to meet her PT goals for gait and safe return to the home environment in less than 24 hours, with pain levels less than or equal to 3 out of 10. She began outpatient physical therapy at 4 days post-op and progressed well in treatment with excellent pain control throughout. By 2 weeks of treatment, she consistently reported her pain as 0 out of 10 and never higher than a 2 out of 10. She was able to discontinue all use of opioid pain medications by her 3rd week post-op and manage any pain with periodic use of ibuprofen. She underwent 13 outpatient physical therapy visits over the course of 6 weeks. Interventions included manual therapy, therapeutic exercises, functional and gait retraining, and the use of cold and heat modalities as needed. At discharge, she did lack 8 degrees of extension with 122 degrees of flexion. Her lack of full active knee extension was hypothesized to be compensatory in relation to a knee flexion contracture she had developed on the right knee following knee replacement surgery several years prior. Other than this knee extension limitation, she was able to meet all of her PT goals at discharge with strength at 5 out of 5 grossly and a 6-minute walk distance of 394 meters, 97% of her age norm. She was able to resume all functional activities, including gardening and walking for exercise, and had no complaints regarding difficulties with her ADLs. Overall, she was very satisfied with the outcome of her surgery and treatment. Limitations with this study inevitably exist due to its small size, but it does open the door for further research on this procedure and lend support for its consideration. Further prospective research on a larger scale would be necessary to determine more objectively how the treatment affects patient pain levels throughout rehab. It is also important to note that many patients do quite well following TKA surgery, but for the patients who struggle with pain prior to surgery, performing this procedure could help to preemptively lower their pain levels, thereby improving their tolerance to postoperative interventions with a reduced need for opioid medications and less likelihood of their long-term use.